Okay. Is it streaming? All right. So I'm going to welcome Dr. Paul Van Donkelaar and Karen Mason, and I'm going to welcome everyone to session 3, stream 3 for the talk today. I'm your moderator, Laura Norwood. If you're looking for a different session, you'll be able to find that on the sessions menu at the left-hand side of the screen. Please click on the session and then you will enter that and be able to attend. Now it is my pleasure to introduce our first speaker for the session, Karen Mason. Karen is the co-founder and director of community practice for SOAR, supporting survivors of abuse and brain injury through research. She is the former executive of Kelowna Women's Shelter in British Columbia, and she brings 30 plus years of experience in private, public, and not-for-profit sectors to her work, advocacy for survivors of intimate partner violence. Our second speaker is Dr. Paul Van Donkelaar. Dr. Paul Van Donkelaar is the co-founder and principal investigator for SOAR. He is also a professor at the University of Columbia and Okanagan campus in Kelowna, BC. Dr. Van Donkelaar's research is focused on the mechanisms of sensory motor control and the cerebral, vascular, neurocognitive, and sensory motor aspects of brain dysfunction resulting from traumatic brain injuries. Since 2016, his work has been focused almost exclusively on better understanding the brain dysfunction in women who have experienced intimate partner violence related to brain injury. Welcome, Karen and Dr. Paul. We are so looking forward to your talk today.
Thank you for the introduction and for inviting us to give the talk today. I first wanted to mention that we're coming to you today from the traditional and unceded territories of the Syilx people, on whose lands we are here as uninvited guests. So today we wanted to talk a little bit about the SOAR project. As was mentioned in the introduction, it stands for Supporting Survivors of Abuse and Brain Injury Through Research.
So we want to start just with some basic facts on the topic of intimate partner violence. Did you know that most extreme incidents of physical intimate partner violence involve blows to the face, head, and neck? And we know that as many as 92% of survivors of intimate partner violence may also suffer a brain injury as a result of the abuse.
And yet most of what we hear about in the media are brain injuries in the context of sport-related concussions. So hockey and football players being the main people that are portrayed and are victims of brain injuries due to playing in those collision sports.
But consider this, in the United States, the Centers for Disease Control says that 2.3% of women will experience a severe incident of intimate partner violence every year. If you presume that same 2.3% in Canada, that means 230,000 Canadian women will experience severe intimate partner violence in a year. Taking that 92% we mentioned in the previous slide, 212,000 women or more are experiencing a brain injury from intimate partner violence in this country every year.
So how does that compare to what we see in collision sports like hockey? Well, if you look at the National Hockey League at a professional level, it's difficult to get the exact numbers, but estimates suggest that around 38 to 40 players will suffer a concussion every year. And so if we compare that to that 212 plus number, it means that for every one NHL player that gets a concussion playing the sport he loves, over 5,500 Canadian women will suffer the same injury in the context of intimate partner violence.
So in intimate partner violence, there are a variety of contexts in which a woman could experience a brain injury. We've got some examples on the screen here. Being punched or hit in the head or kicked in the head can happen when a woman is violently shaken or thrown down the stairs or out of a moving vehicle. We also have to talk about strangulation. Strangulation happens in about half of cases of intimate partner violence. And it is incredibly dangerous and is a very large red flag for future mortality. Strangulation can cause brain injury and it can cause death within minutes. We know from research that's been done in the United States that women who are strangled are 750 to 1,000 times more likely to be murdered in a subsequent attack by that same partner. So we always like to talk about some of the signs and symptoms of strangulation because not everybody is aware of them, even those who work on the front lines with women in the gender-based violence sector. So it only takes about 33 pounds of pressure to close off someone's windpipe and close off that flow of oxygen and blood to the brain. It takes 20 pounds of pressure to open a can of pop. So that 33 pounds isn't very much. Signs and symptoms to look for from strangulation are raspy voice, trouble swallowing or breathing, ringing in the ears, red spots in the eyes or on the skin. That's called petechiae. Someone might experience scratches or bruising on the neck or the face, often from trying to remove someone's hands or a ligature. They could report loss of memory, loss of consciousness, maybe uncontrolled urination or defecation. And the really important one here, sometimes someone could have been strangled and have absolutely no visible signs and symptoms, but they could have experienced internal injuries that, if they go unnoticed, could cause severe injury or death up to a year after the incident. So strangulation is a really important factor to keep in mind when we're talking about brain injury and death from intimate partner violence. This is just another graphic that shows some of those signs and symptoms. A couple on here I didn't mention: bite marks inside the mouth, swollen tongue or lips. Now, we know that brain injury can be an invisible injury. It's not like you've got a cast on your arm or on your leg, but it can cause a range of signs and symptoms, and it's important to know what those are when you're working with women. So women can report all of these factors if she's experienced a brain injury from intimate partner violence. In the context of seeking service, for instance, at a women's shelter, in another context, this is a list of some of the ways that a brain injury might manifest. So a survivor might appear to not be listening, not to remember things or learn things. Perhaps she's easily distracted and she can't follow instructions. Maybe she seems tired all the time, really irritable, gets angry. She can't get along with anyone. She rages at you. She rages at her kids. She has trouble adapting to changing circumstances. And maybe she seems to change her story if she's giving you that discourse of what might have happened to her. These are really important things to know and to consider, because taken on their own, you might just think a woman is being difficult or oppositional, or maybe just has some other mental health issues. But if you look through that lens of brain injury, you might see something else. And yet, most sectors who serve women are not considering brain injury so far. In a survey that we did early in our research project, we found at least 75% of frontline women's shelter workers had never done any kind of official or informal screening with their clients for brain injury. Yet, given the numbers we talked to you about before, we know that most women who are being served in these contexts have probably experienced one or more.
So in response to this, we started the SOAR project about 6 or 7 years ago now. So just to give you some sense and orient you, it's a community-engaged multidisciplinary research initiative started in 2016 in a collaboration between UBC Okanagan and Kelowna Women's Shelter when Karen was the executive director there. And we began data collection about 5 years ago. So the goals are threefold. The first is to do what we call explore, which is to characterize the incidence and effects of brain injury and intimate partner violence. The second is to educate, so educate and train frontline staff and others working in the gender-based violence sector about this intersection between intimate partner violence and brain injury. And then the third is to empower, to create better an awareness and support services directly for survivors that take brain injury into account. So we do this in a number of different ways. The first is to collect kind of foundational evidence to show the link between brain injury and intimate partner violence. And to do this, it's important to take into account all the comorbidities that can come along with intimate partner violence. So things like post-traumatic stress disorder, anxiety, depression, trauma history, quality of life, substance abuse, and then a scale that was developed by a colleague at Harvard University, Dr. Eva Valera, called the Brain Injury Severity Assessment Scale.
One thing that we've really worked hard to do in this work is to ensure that we're coming from a trauma-informed place. So these assessments for all these factors are done one-on-one in the context of the Kelowna Women's Shelter with one of our team members who is also a staff member at Kelowna Women's Shelter. So those women who are doing these assessments, which can be triggering and re-traumatizing, are protected in that they're in a safe space, a place with which they're familiar, working with someone they already have a relationship with, and with those supports in place. That was a really key piece of setting up this work for us, that we knew that the primary goal was to keep women safe through the whole process of the research.
So after we do those assessments of the comorbidities and the brain injury severity, we bring them up to my lab at UBC Okanagan, and we do a number of different assessments of brain function. Many of these assessments are things that we've done previously in the context of sport-related concussion, so we can make comparisons to that athletic population. So we do assessments of neurocognitive function. We do brain blood flow measurements to look at aspects of cerebrovascular physiology. And then we do some blood draws because there are various biomarkers in the blood that are consistent with the fact that a brain injury has happened or the brain has responded to an injury in a certain way. And so in the interest of time, we're just going to give a summary of the evidence that we have so far. We collected data from just over 60 participants before the pandemics struck. And based on the brain injury severity assessment tool, we found the majority of these participants, 92%, had experienced at least one IPV-related brain injury. Those that had experienced strangulation as part of those episodes of intimate partner violence tended to have higher brain injury severity assessment scores. There was an overrepresentation of Indigenous women within our study population. So 20% of our participants were Indigenous, whereas the general population in our region of British Columbia is 7% Indigenous. I mentioned before that we've done this research and many of these measures in athletes who had experienced an acute sport-related concussion. And so one of the things we were able to do is compare the number and severity of symptoms in the women who had experienced intimate partner violence-related brain injury to previous participants that we've looked at in the lab who had experienced an acute sport-related concussion, and found that the IPV participants had a greater number and severity of symptoms than these young athletes who had just suffered a sport-related concussion. The brain blood flow assessments allowed us to demonstrate that there was this idea of arterial stiffening. So the blood vessels going into the brain were less pliable, less able to change their diameter in response to changes in blood pressure. And that was related to the severity of the IPV-related brain injuries the women had experienced. And that arterial stiffening has been linked in other studies to longer-term neurodegenerative disorders. And then looking at kind of some of the neurocognitive aspects, we found that there was a reduced ability to make fast coordinated movements under complex situations. So just the ability to process the information and make responses quickly was compromised. So kind of the bottom line is that in IPV, these participants had experienced repeated brain injuries that resulted in chronic symptoms and had potential long-term consequences in terms of their long-term health.
So the second key goal of this project, as we mentioned earlier, is to educate. And we have been working really strongly on that piece since we started the project in the early days. We started by surveying 150 women's shelter workers from across Canada to get a sense of what they knew about brain injury, what they knew about brain injury from intimate partner violence, what they wanted to know, and how best we might give them training and tools to learn more. Because we found, as we mentioned earlier, that 75% weren't screening for brain injury. And in fact, most didn't know about the connection between brain injury and intimate partner violence. I certainly didn't before we started this work, and I was running a women's shelter at the time. And they told us that they needed tools and education that fit their busy schedules and the sometimes chaotic nature of working in frontline work at a women's shelter. So one of the first pieces we developed is the concussion awareness training tool for women's support workers. It's an online course that is based on an existing suite of tools called the concussion awareness training tool. And this module, specifically for people who work with women, takes about 35 to 40 minutes to complete. It's quick, it's easy, it's available in French and English, and it's free. So that's one of the key pieces we've developed. We highly recommend, if you haven't taken it, it's a great way to get all the basics you need to know what you're looking for in terms of signs and symptoms and how to support women who've experienced it. Concurrently, we developed some brochures and other resources that could be used by both frontline workers and survivors. So we have the basic moving ahead guide to brain injury and intimate partner violence for both workers and survivors. And we also, after talking to shelter workers and assessing a few different brain injury assessment tools, landed on an adapted version of what's on the screen, which is called the HELPS tool. It's a really straightforward 5-question survey that can really give you a good sense as to whether a brain injury may have been part of a woman's experience based on things that may have happened to her, whether she's been hit or she's been shaken or strangled, and the sorts of signs and symptoms she's experienced. Our shelter workers told us that they didn't think having a formal screening tool would be helpful. They wanted something that they could use as part of a conversation with their clients and do as part of their long-term interactions with clients, as opposed to another survey to do at intake. Those of you who work with women in this context know what I'm talking about. So this is what we developed for that. And all of these resources are available on our SOAR website for download. We've also provided them to the conference organizers so that they can make them available to everyone who's attending the session today. And then in the past 6 to 8 months, we developed a specific brochure on the topic of strangulation. Given strangulation does have some unique nuances and is absolutely the biggest red flag for future mortality and a cause of brain injury, we wanted to provide something that dove a little deeper into this topic. So we have a worker's guide and a survivor's guide specifically on the topic of strangulation that you again can download and use at will. And all of these are available in French and English, thanks to support we received through the Federal Department of Women and Gender Equality, which I believe is also a big sponsor of this conference.
The final phase of the SOAR project is like what we call Empower, and it's implemented in the context of what we call the Community Support Network. So it's a partnership with, again, the Kelowna Women's Shelter and a community brain injury support agency here in Kelowna. And we've implemented a multifaceted intervention that includes aerobic exercise, mindfulness meditation, occupational therapy, counseling, and cognitive exercises. In addition, a key component of this is having a participant navigator there to help the participants negotiate their way through this intervention and any other things that may be affecting their ability to participate in the intervention. In terms of how we're looking at the Community Support Network, one of the things we're doing is to identify, using mixed methods approaches, the gaps and barriers to accessing appropriate supports that take brain injury into account. We're surveying and evaluating participants before and after the intervention to measure changes in quality of life, resiliency, and neurocognitive function. And we've just completed the first cohort of participants over the past few months, and all of them showed measurable improvements in these different evaluations that we're looking at. So there is the potential with this type of intervention to show some long-lasting and significant improvements in a number of different aspects of brain function.
Yeah, it's been interesting for us in doing this work and realizing that, you know, for instance, an athlete or someone who's come back from a war zone, there is a specific and very well outlined pathway of care for these people who've experienced a brain injury. You know, for an athlete, there's the whole return to play protocol, which Paul knows way more about than I do, that sets out how much rest is required, what sort of interventions are required to help with recovery, when someone is ready to go back. With women who've experienced a brain injury and intimate partner violence, we don't have a return to life protocol. Women often in this context don't even realize they have experienced a brain injury. We found in the work we've done and the women we've worked with. And if they have sought treatment, there is no specific pathway of care for women coming to that, from that unique context of intimate partner violence, which so many service providers still don't understand. And there isn't the kind of trauma-informed support that we know is needed. So having a participant navigator as our clients work through this intervention has been a really key piece of being trauma-informed, as we mentioned before, that these women are having a hard enough time navigating life to also then have this intervention, which will help them, but to still be doing things to deal with, say, child custody or housing issues, or perhaps they're still living with their abuser. Having this navigator who is a member of our team, but is also a certified clinical counselor who has lived experience with brain injury, has really been an important piece of making this intervention work for these women and be trauma informed. So I think that's partly why we've seen really positive results. And we have a new cohort that's just into the intervention now, and we're excited to see what results they get.
We have a number of other things going on, including some aspects related to potential unintended consequences of a brain injury diagnosis in women who've experienced intimate partner violence. So had a master's student that recently completed his degree looking at the ethical and legal considerations of screening and how that information might be used or misused or weaponized in the context of family law court proceedings.
We, from when we first started this project, it came up time and time again when we spoke about how high these numbers are and the need to help women and provide them services. We heard time and time again from women's shelter workers, we don't think it's necessarily safe if we're going to be telling women they have a brain injury, because it's another thing that the Ministry of Children and Families perhaps, or their partner might use against them. So this was a really important piece of research to get a sense of what that looks like and how we can conduct screening so women know what's going on with them and can get help, but without it being weaponized against them. And there were some interesting, but unfortunately not surprising findings.
Yeah, and the main finding is that the legal system currently is not that great for women who've experienced intimate partner violence, and so adding brain injury to that context probably makes it a little bit worse again. And so kind of one of the recommendations coming out of this work was increased education and training for those that work within the legal system, including judges, around the intersection between brain injury and intimate partner violence. And I think we're seeing this as well in some of the recent legislation federally in terms of coercive control. And so it's the same principle, right? Making sure that those who work in the legal profession know of this connection and can take it into account in some of their judgments or arguments. We're continuing with our lab-based assessments. We're finally back into the lab now after the pandemic, which shut down a lot of face-to-face human participant research. So we're continuing to collect blood draws to do a more complete set of biomarker analyses. We're also going to be looking at hair samples to look at chronic stress responses. And in addition, do some additional assessments of more aspects of neurocognitive function. Another grad student that just started with us last year is interested in the intersection between brain injury and intimate partner violence in the queer community and other marginalized populations. So in LGBTQ2S+ communities, it's known that there are higher incidence or rates of intimate partner violence, but what's not known is whether brain injury is part of that experience or whether it's a part of it to the same extent it is in heterosexual couples. I have another new grad student working on the SOAR project who is a 25-year veteran of the RCMP and recently retired. And so she's very interested in this training and educational piece around making sure that law enforcement, first responders do the right thing and ask the right questions when they show up at an IPV call. And so we received some internal funding to create a simple virtual reality training tool for use in law enforcement, where we would train them in different scenarios and have them implement interventions and questions and procedures that take brain injury into account, because it's very likely that it may have occurred. And then we have one more new PhD student working on the project who's a paramedic by training. And just like with the RCMP, paramedics quite often are the first responders to intimate partner violence calls. And so making sure that they ask the right questions and do the appropriate assessments to take intimate partner violence and brain injury into account is also a high priority. In reviewing the current assessments that paramedics do around intimate partner violence, it turned out, at least in BC for the emergency pre-hospital care, that IPV appears under a code for mental health issues as opposed to assault. And so it seems like it would be an appropriate place for there to be some rethinking around those sorts of assessments and how they get categorized. No.
So one of, it's really easy for us to talk about the research shows as many as 92% of women who've experienced intimate partner violence have probably experienced a brain injury. So we need to look for it and we need to provide support and healthcare for it. But there are a lot of challenges in doing this work. As I mentioned earlier, it's an invisible injury, and even more so than, say, a head injury from sports, because it's often not witnessed except maybe by children in the home. So that makes it difficult. We also have comorbidities that exist, which make it hard to disentangle what you're looking at. And this actually relates to the question that has come up in the chat about people who've experienced complex PTSD. I too experienced complex PTSD from a 22-year abusive relationship before I met this kind and lovely man. Many of the same symptoms can display in both instances. So teasing apart whether something's been caused by a brain injury versus from complex PTSD or some other factor is really difficult and adds challenge. Of course, there's the existing shame and stigma around intimate partner violence and lack of knowledge and awareness about brain injury, about intimate partner violence, and about trauma-informed practice. One thing we've realized is we have to train anyone who works with women about trauma-informed practice, because even if you're an expert in brain injury, if you don't understand the nuances and complexities of abuse and can't speak to a woman in a trauma-informed way, you won't be able to help her. There's also, of course, for the women who often are still in an abusive relationship, fear of repercussions. Because they've had a brain injury, there's a difficulty in safety planning in the first place and acting on a safety plan and then preventing subsequent injury. All these other factors, financial limitations. One reason we're able to do this intervention we're piloting is through funding from the federal government, but it's not cheap. So if the healthcare system isn't able and ready to step up and fund it, how are we able to help these women? So lots of challenges we're dealing with. In terms of you and your work on the front lines, if you're working with women and you, either from what she's told you about a mechanism of injury that she got beaten up the night before and she's displaying all the signs and symptoms of brain injury, you're going to want to refer her to a doctor, of course, but also your local brain injury support agency. But there are things you can do in your daily work that can help. And these can help whether she suffers complex PTSD with or without a brain injury, to be honest. Speaking slowly and clearly, as you can tell from this presentation, I'm not great at the slowly part, but we're trying to get a lot of information in a short period of time. Taking breaks, because a woman who's experienced a brain injury can get overwhelmed very quickly. Also, you want her to repeat information back to be sure she's understood you. Sometimes the severe lighting and noise can be difficult, so dimming the lights or moving to a less loud and lighted environment. Helping her fill out forms is really key. I know in the work I did at the women's shelter, women would arrive and at intake, we'd hand them a pile of papers, applying for social assistance, applying for housing, applying to get legal aid support. Doing that or sending her to the computer with 5 links for forms she has to fill out is not going to be helpful. You're also going to want to minimize the computer use. Encourage rest. Help prioritizing with tasks. You can give her day timers. A lot of offices keep small day timers that they will work with the women to use and help with, show them how to use the date reminders in their phone, and even keeping sunglasses, hats, and earplugs in your office to help women who are having trouble with the bright lights and the noise. You can, of course, also educate yourself even more. First step, you're here today, so thank you very much. Taking the concussion awareness training tool course for women's support workers is a really good step, but there is more. The ABI toolkit is a wonderful resource developed by our colleagues from University of Toronto, the ABI Research Lab. If you have the time and the interest, it is a deep dive into everything you could ever want to know on this topic and much of the research that's been done to date. In terms of trauma and violence informed care, the researchers at the University of Western Ontario and the Equip Healthcare Group have done some incredible work about making the work we do more trauma and violence informed. This is just one of the resources, but if you check out their website, they've got a lot of great stuff, and I highly encourage anyone who wants to do more in their practice to check out what they have.
So that's all we have. We'd like to thank the various funders who've helped support this project. We have a major grant from the Department of Women and Gender Equality, which has really gotten us off the ground. And we'd love to be able to stay connected after this conference. So there's our various social media presences, as well as our email addresses. And so we'd be happy to take any questions right now.
So I'm just going to start and say thank you very much, Karen and Dr. Paul. We're very grateful for this conversation today. For those interested in asking some questions, I've seen lots of information go through the chats. So I'll go back through and I can ask some of the questions that were in the chat there. But if you have any additional ones, please feel free to communicate that in the chat at the bottom of the screen.
Paul just has to let our cat out. So this is the joy of Zoom and working from home, everybody, right?
Exactly. We totally understand.
The minute we get on a call, she's scratching to come in or she's scratching to go out. So she'll probably be back in a minute.
It's totally fine. No problem at all. No problem at all. So if anybody has questions, feel free to include those in the chat. Please don't raise your hand because we can't see those. And don't add the chats into the Feedloop platform because we want to actually be able to see those. And I will go ahead and just quickly review some of the ones that were asked earlier. So Mary was making comments about how, and I think you may have noticed this, Karen, how PTSD has potentially had impacts on neurocognitive function. In your experience, have you also explored how trauma through, non-strangulation, but just through engagements in verbal abuse or psychological abuse has also had impacts?
Yeah,
Absolutely.
So I can speak to that. And Karen spoke a little bit to it during the presentation, but I didn't have time to get into the details. But the brain injury severity assessment tool, you actually end up with a score from 0 to 8 on that assessment, where 0 means you have been exposed to intimate partner violence, but if it was physical, it was not directed at the head, face, or neck, or potentially it was psychological or emotional or financial or some other form of intimate partner violence. So the idea being that in that context for those participants, they would still likely have some of the same comorbidities, depression, anxiety, substance use, PTSD that come along with IPV, but they wouldn't have the direct effects of head impacts or strangulation. And then, so then comparing how people who score low on the brain injury severity assessment versus those who score really high, which is equivalent to they were hit or strangled many times. Perhaps the most recent time was only a few weeks ago, and maybe on one or more occasions they might have lost consciousness or had a period of post-traumatic amnesia. So very consistent with a brain injury occurring. Then when we apply that tool and see how some of the different measures we do in the lab are related to those scores, we get a better sense of basically the impact of the severity of the brain injuries that resulted from the IPD and how that might compare to those that didn't have or had far fewer brain injuries due to IPD. And so, yeah, it gets quite complex in terms of disentangling the various comorbid factors from the brain injury itself.
At the same time, however, I've spoken to a lot of folks who do this work who speak about the reality that the things that have been proven to support healing from brain injury and better function in the world are certainly not going to hurt someone who's experiencing other impacts of trauma. So we tend to tell folks who are working in the front lines, if you're working with a woman and she's been in intimate partner violence, it's not going to hurt anyone if you presume there may have been a brain injury and you throw all the tools you have at her.
Yeah, that's fantastic advice. And this is what, again, it's bringing all of our knowledge together to collectively create tools and resources so that we can early identify and then come up with prevention strategies or solutions to help support the women that are recovering or going through this process. I have a question here as well. Somebody's commenting, they're saying, thank you so much for the presentation. They're very grateful for the information that you're providing about the nuances in the topic. It's not so obvious, but it's critical. So they're saying, thank you so much for your work.
Thanks.
That was from Sophia. And then Mary's asking about how can someone become a volunteer to be tested?
Well, Mary, do you live in Kelowna?
I'm not sure. I think Mary's out west. She's in Alberta, I believe.
Okay. Well,
yeah.
we do have, Mary, I would suggest you've got my email address there on the screen. Why don't you send me an email? We do have a colleague who isn't in BC, is doing some work in Manitoba.
Okay.
So there might be someone we could connect you with. In terms of the work we're doing right now, it's specific to folks in BC just because of some of the limitations on what we're able to do. But I'd love to chat with you further and see if there's any way we could support you if you did want to find out more for yourself.
Yeah, one of the advantages of the pandemic, there weren't very many, but is that we did switch to doing some of our assessments in an online format. So that is a possibility.
Yeah.
So yeah, absolutely get in touch and we can see about connecting.
Yeah, it's, you know, one of the things that's been wonderful, but also incredibly frustrating in doing this work is it was very clear very quickly that this is a massive hidden issue. It was very clear very quickly that we need to educate literally anyone who ever works with women when you look at the numbers.
Yeah.
And then we got to, if we educate everyone, well, then what? How do we help people? What are the systems that are in place and how do we make those happen? So this project sort of started like this and went like this, as Paul will say, very quickly. There's a lot of work to be done. We've been working with, certainly here in BC, with our Ministry of Children and Families that are the frontline child protection social workers, because we, again, think about what if a woman has her children removed by Child Protective Services when in fact the issues she has are a direct result of her former partner, and maybe there are services and supports that could help her be a good, healthy mom and look after her kids and keep the family together, but no one knows anything about them. So we're working with them to get that training to our frontline social workers. We're working with legal aid to ensure that our legal aid intake workers and lawyers understand, but it's a huge job. So anyone out there who's interested, compelled at all by this topic, I am keen to do training workshops with anyone who's interested. So please get in touch because that's my passion, is getting this work out there.
Fantastic. Well, thank you very much for that, Karen. And again, there's many thank yous coming through the chat. So this is, we're so grateful for the work that you're doing. This is going to be very helpful for the tool that we're putting together for the Abuse Hurts team here and our knowledge sharing that we're going to be presenting. And we'll be in touch as well after the presentation to further the conversation, because we can see that there will be some very helpful things here that would benefit for our learning purposes as well. And if there's, I don't see too much
Any other questions?
Any other questions? I don't see any more questions right now in the chat. I'm just going to review one more time.
How many people do we have on the call today?
We've ranged. We've gone upwards of 40 so, and we're at 24.
So since I don't see any more questions right now, and we have a couple more minutes,
yes,
I'm going to guess that some of the people on the call are single or have recently been single and online dating. So if you are, and if you're like, you've had it up to here, I want you to know there's hope, because Paul and I met online dating almost 7 years ago, me running a women's shelter, him a sports concussion researcher, and this wonderful project and our partnership is the result. So I just sometimes, if we have time, I like to tell the story because I hope it gives people hope that it's never too late to find your wonderful partner.
Oh, that's so beautiful. Thank you so much for sharing that. That's so lovely. People are saying, yeah, they're sending lots over there. Waiting.
And yes, as I said, I have a 22 history in a violent relationship, and I too came out of it with many scars and many fears. So again, if you decide to be brave and seek love again, it is possible.
Thank you, Karen. I think he's
also really cute.
Beautiful success story. You're both very cute. You make a wonderful couple. And the work you're doing is incredible. So we're very grateful again. Thank you so much. And then people are expressing that as well. So that's lovely.
Thank you for having us.
Thank you. We'll give you some time back. We know you have another conference today. So again, thank you so much for attending the session. For everyone else, you have a little bit of time, so you can head back into the lobby if you would like to. We're going to have our closing remarks. So please make sure you head yourself back to the main stage for 4:05. And we will see you all there. Thank you, everyone.
Thanks.
Take care.
Bye.
Bye. Bye.